Okay, so we're back, and let's talk about sexuality in adulthood, ages 25 to 65. Okay, so sexuality. What are some of the myths? That if you get married, you'll never have sex again. That if you have children, you'll never have sex again. That if you turn 40 or 50 or 60, you'll never have sex again. The Is There Sex After Marriage book and the Is There Sex After 40 were legitimate books that were published in the 70s. These are myths. Here are the real things. This chart doesn't necessarily indicate whether they had children or not in present, but what we're seeing is sex frequency by age and marital status. And so we see the married men in the blue line, the married women in the hot pink line, the unmarried men in the yellow line, and the unmarried women in the turquoise blue line. And so what you see is that the married men and women are having more sex than the unmarried men and women. Interestingly, the unmarried men 60 and over are doing pretty well. That's kind of an interesting little anomaly, and we'll talk about that later when we get to that age bracket, but I'm just interested right now, right? And I guess 60 is part of our age bracket. But I don't feel like we're ready to talk about retirement homes yet because we're talking about people who are largely still working. So we'll get to that later. But you'll notice that for unmarried women, after the age of about 50, we're seeing a significant decline in sexual activity. And overall, both sexes who are not married are not having as much sex as married people. So kind of what we're seeing is that, yeah, there's a decline in sexual activity with age. But I think we can debunk the myth that there's no sex after marriage. And I think we can probably debunk the myth that there's no sex after 40. There's probably less frequent sex, but I don't know if that's even a statistically significant difference between the 40-year-olds and the 25-year-olds. I don't know if that's even significantly different. Okay, so those are positive things. Okay, how about sexual responsiveness? In males, we do see that with age, arousal slows. So it's not like, again, it's kind of like the reduction in strength or the reduction in reaction time, that, it's not really that noticeable between, for the individual as they're aging. They don't notice that something's changing necessarily. If we compare how long it takes a 25-year-old to become aroused and how long it takes a 65-year-old to become aroused, we'd probably notice that there's a different amount of time. It does take longer for older men to reach orgasm. So with age, it takes longer, which actually can be a pro, right? That can be a benefit. Because a lot of times, the number one complaint that men report to their doctors or to experts in sexuality is that they've experienced premature ejaculation. So slower orgasm can be a benefit. Men report greater satisfaction when they're in monogamous relationships than when they are in when they're single. Even if they're having the same amount of sex as the monogamous person reports greater satisfaction. Now, this chart is just showing the percent of people who report that they're comfortable in monogamy. That doesn't necessarily mean that they're sexually satisfied, but that they report that they're comfortable with it. And you'll notice that men, starting with the age of 45, are reporting even greater levels of satisfaction with monogamy than women. We tend to have that myth that women are the ones who want to be in monogamous relationships, but men tend to be more comfortable when they're in monogamy. By the age of 55 to 59, then the sexes start to match on that again. So greater satisfaction when monogamous in men. How about fertility? Most women will have children between the ages of 25 and 40. With increased age, there is an increase in birth defects for both, and with the increased age, we're talking about for both the men and for women. The likelihood grows with each year that their offspring are more likely to have birth defects. So I thought I'd run through several examples. Here we have maternal age and then the rates of Down syndrome in their offspring. And you'll notice it's pretty much on the floor. I mean, like very few women up to the age of 25 are having children with Down syndrome. It's still pretty much on the floor between 25 and about 32. And then it slowly starts to rise. And then it suddenly, at age 40, dramatically rises. So one hypothesis is that with increased age, the eggs that mom has been carrying with her since she was in the womb herself are starting to age, and the chromosomes in them are starting to decay and be malformed. Given that Down syndrome requires 3 chromosomes in a particular area, I'm not sure if that's the best explanation for what causes Down syndrome, but something about the aging process contributes. Here we have the probability of autism spectrum disorder, and we've got maternal age on the left and paternal age on the right. And so what you can see is that with age, there's a higher rate of autism spectrum disorder in the offspring, whether you're talking about mom's age or dad's age. It's higher. You have a much higher probability of your child having autism if either of you is over 40. And for mom, it really starts to rise around age 35. Schizophrenia is associated with advanced paternal age. So dad being older is associated with a higher risk of schizophrenia in his children. And you'll notice that for dad's age, that really dramatically increases after the age of 30. So we're seeing a lot of evidence that 30, 35 should be the age that we're going to start targeting as when risk starts to go up. Here are some common genetic conditions associated with advanced paternal age, and you'll see this is a pretty long list. If you're really curious, you can pause this slide and read through the list, but that's a lot of different disorders that have been associated with dad being older, and usually what we mean by dad being older is over 40. Here we have mom's age and the risk of her child having any chromosomal disorder, and you'll notice that at 20, she has a 1 in 526 chance of her child having any kind of chromosomal disorder, and by the time she's 45, it's a 1 in 21 chance. I mean, that's still only about 5% chance at the age of 45 that your child would have a chromosomal disorder, but you can see that with advancing age, pretty much starting at the age of 35, you're starting to look at dramatic increases in the risk of the child having chromosomal disorders. Okay, so that kind of suggests that the best age for reproduction might be between 25 and about 35. Well, let's be honest, probably between 18 and 35 is the most ideal time for mom physically to produce the healthiest offspring. We talked before about the social impacts of being less than 25. For dad, we're talking about probably 25 to 40 as his ideal time. About 15% of American couples experience reduced fertility. Some may be what you would call infertile because no amount of intervention would actually ever produce an ability to have children. But we call it reduced fertility because now today with different interventions that we have available, most couples can have some degree of fertility returned. It's most common when parenthood is delayed. So when couples start to be over the age of 30, starting to push towards 40, it makes it more and more likely that they may experience reduced fertility. Now, things that can cause reduced fertility, you'll see 40% of the time it's going to be due to something about the male reproductive system. 40% of the time, 50% of the time it's going to be something attributable to the mom. So endometriosis, ovulation problems, or blocked fallopian tubes. And then there's another 10% that's unexplained. They're not sure why it happens. Maybe it might have something to do with the combination of these two people, and that's what's going on. But what you'll notice is it's almost equally likely to be something having to do with the male as it is to be something to do with the female. And that's important for couples to know because a lot of times the female feels like it's her fault, and the male will kind of encourage her to get all the tests to clear her because, I see that something is coming out of me when we have sexual intercourse, so I must be okay. And they don't realize that there might be more to it than just whether or not you can ejaculate. And so couples need to sort of explore both partners. And the easier investigation is into the male to see if everything's working for him. That's the easier thing to do because all it requires is to ejaculate in a cup, and then they check to see if the sperm are alive. For the female, there can be some pretty intrusive tests to determine whether she has endometriosis or if she's ovulating, or to check to see if her fallopian tubes are blocked. So the male tests are so non-invasive, it seems like they should probably be done first, but in a lot of couples, they aren't. The male gets tested after all things having to do with the female have been excluded. And that's kind of unfortunate because it's no more likely to be the female than it is to be the male. Speaking of infertility, though, menopause. Menopause is when you actually stop menstruating and stop ovulating and therefore are no longer able to reproduce. The process of going through menopause is called the climacteric. It's a 2 to 4 year period when the hormones are changing that are taking the woman from ovulating and menstruating and capable of reproducing to a person who no longer ovulates or menstruates and is no longer capable of reproducing. Now, the hypothalamus, if you recall back from adolescence when we talked about puberty, this is sort of the reverse, right? The hypothalamus governs the hormone levels by activating the pituitary gland to release luteinizing hormone and follicle stimulating hormone, which then trigger the ovaries to ovulate. And when the ovaries ovulate, they also release a big dose of estrogen and progesterone later that will, protect a fertilized egg if one were to occur. So that's what is happening in a typical menstrual cycle. During the climacteric, the hypothalamus stops sending the message to the pituitary gland, and then in turn, the pituitary gland stops sending the message to the ovaries. During this climacteric period, you'll see that the hormone levels actually get higher briefly as the body is trying to tell the ovary to ovulate, and so the ovary starts to become non-responsive, and so the brain is sending out the message, and the ovaries are no longer responding. The hypothalamus, you got to remember, is in part going to be governed by genes to determine the timing of the climacteric. So partly, a woman can kind of get an idea about when she might expect menopause to start, the climacteric to begin, by looking at what her mom went through or what her grandma went through or something like that. So it's partly governed by genes, but it's also partly governed by the environment. So when there's stress or other kinds of factors that could interfere with the functioning of the hypothalamus, it can trigger the onset of menopause earlier or later than the genes might have normally on their own have argued for. So some of the symptoms of the climacteric. Okay, so this I thought was a really interesting way of depicting the symptoms. So in the lavender bars are women who have completed menopause. So these aren't the women who are in the climacteric. They're done. In the green bar are the women who are going through the climacteric, the menopausal transition. And then what color is that? Gray? Would be the women who are still reproductive, they're having ovulation and all those, they're having menstrual cycles and all the other things. So you'll notice, first off, there's a range for each of the bars. So there's a range of, the percentage of women who report these symptoms. And you'll notice there's some overlap among the women who haven't started menopause yet, those who are going through it, and those who have completed it. So it kind of implies that a lot of these things are not necessarily attributable just to changing hormones. There might be more going on. So for example, mood symptoms. There's not a whole lot of difference between the different groups of women on the rates of mood symptoms. A little less prevalent in women who are still reproductive. Urinary complaints, it looks like more reproductive women are reporting that than the ones who are going through or have completed menopause. Sleep disturbance, again, it looks like more pre- and post-menopausal women are reporting that than women who are in the process of going through it. Vaginal dryness seems to be the one thing that is the biggest complaint of women who are going through it. It's much more common among women who are going through the climacteric than it is in pre- or post-menopausal women. And then vasomotor symptoms are talking about, vasomotor has to do with your vascular system. And you'll notice that there are more complaints pre- and post-menopausal than there are during menopause. So kind of interesting to see the variation in what women complain about at different stages of their lives. Menopause is considered to be complete when you have had an entire year without ovulation, and an entire year without menstruation. So usually when a woman reports to her doctor that she's starting to experience, long spans between periods or really short spans between periods, it could go either way. The doctor, and she's of a certain age, the doctor will then order usually a test for follicle stimulating hormone. And if her follicle stimulating hormone is really high, that indicates that she's probably perimenopausal, that she's trying to ovulate, but it is not working, because then she would be having a period if it was working. So that's usually the way that they diagnose that a person is actually in the climacteric or going through menopause. The average age for the completion of menopause is 51. A lot of women mistakenly think that that's not the average age, that that's really young, but 51 is the average age. A lot of women today delay that age by using birth control pills beyond when they're necessarily needing it for birth control, or take hormone replacement therapy longer, to sort of draw out the process of ovulation and things like that. So, but 51 is the normal, typical average age for completing menopause. All right. What about men? Andropause. Male menopause. Andropause would be referring to a reduction in testosterone. Around 55, men start to report some symptoms that are associated with declining testosterone. So they start to complain about things like tiredness, decrease in strength and muscle power. I got this from the internet. There's some product that you can buy that's supposed to make you stop feeling like that guy. Male menopause is a little bit oversold. If you look at testosterone levels in the blood, so you've got plasma levels per liter of blood, and you'll notice it's a slow decline for men, which is nothing like what women experience. Women experience just drop off a cliff of estrogen. Men have a slow decline. And so just like I've been talking about with strength or reaction time, the changes are not really that noticeable. So for most men, this is not what they report. This is not, these are not symptoms of reduced testosterone. These are symptoms of, first off, you got to love that they can't spell lack. Notice that where it says lack of confidence. I'm starting to think this might not be a professional product. But most men don't experience these symptoms as a function of reduction of testosterone. These are symptoms that you get from lack of exercise and poor diet and too much stress at work and things like that. So we've got lack of confidence misspelled, and let's go 2 lines down and see that it says feeling of lost. Not sure what that means. Anyway, so men don't really go through a male menopause. Let's go ahead and take a break here, and I will come back and talk a little bit about osteoporosis and some other fascinating conditions.